Hi, so I'd like to thank the chairs so much for inviting me to speak today. It's been a journey for me preparing this talk, and I hope looking at the audience you'll be able to teach me some things as well. So I have some disclosures to disclose, and I didn't warn you about this before, but I have actually slightly changed the title a little bit, and I am going to talk about menopause, the perimenopause, and MS. So I think this is a subject which we don't often see on programmes in MS conferences until perhaps this year, when I'm aware that some of you may have heard a couple of other speakers talk about the subject. So hopefully we'll cover some slightly different things as well as recapping what you've already heard about. And I think quite rightly, there's been a lot of press and a lot of publicity in the last few years about the menopause, partly from Davina and from other celebrities, and I think this has improved awareness. I think there's been a bit of a danger of a backlash and people being accused of jumping on the bandwagon. I don't believe that, but I think I have heard that. But I think this year, encouragingly, the Department of Health, and this was published, the Women's Health Strategy for England, and this was recently only updated a couple of weeks ago, and recognises that 51% of the population are female, and whilst we have a longer life expectancy than men, actually we spend a longer time in poor health and disability than men. And actually I think we've probably all appreciated that the healthcare service has been designed predominantly by men and arguably for men. So this, I feel slightly comfortable saying this. I apologise to the others, but there was some deep breath saying that. But you guys
are suffering from an X chromosome deficiency.
Well, and to be fair, I think men suffer the effects of women's poor health as well. So that. So menopause is one of the big topics within this health strategy, and there are several key themes which have been brought up, and information and education is very much one of those. And the ambition is that the education is going to improve, and I don't know about other kind of medics and nurses in the room, but I don't remember getting particularly good information and education about menopause when I was at medical school. The timing of when I was at medical school is quite interesting, and I'll talk about why that might be later. But actually, as kind of neurology professionals, we have been highlighted as a group of people that should be particularly aware and have a basic understanding of menopause. We're not going to be GPs, we're not going to be obs and gynae specialists, we don't have to know everything, but I think we do need to know something. So, a few definitions I think it's important just to highlight. So, the menopause is defined as a year after your last menstrual period. So it's a clinical definition. The perimenopause, however, is that time leading up to the menopause and can last up to 10 years. And I think one of the common problems which women come across when they complain of hormonal problems is that, oh, but you're a bit young for that. And lots of recognition about that. And I've experienced that myself. And actually, by definition, any woman, and this is if you have an average age of menopause, will be perimenopausal from about the age of 40, 41 onwards, potentially. Not everybody has symptoms, but there's the potential there. And of course, this is not an on and off switch, and that's why I think the perimenopause is so important to speak about. Your estrogen levels is a hormone produced by the ovary, and that declines after a peak in your late 30s and declines after that until the low levels in later age. So it's not an on-off thing, it happens gradually. So just a few statistics. The average age of the menopause in the developed world is 51, with a span of 45 to 55. But actually premature ovarian insufficiency or early menopause isn't that uncommon. So 1 in 100 women will develop this before the age of 40, and 1 in 1,000 below the age of 30. So this is something that we should be aware of even in our younger patients as well. Now, there has been some accusations about over-medicalising the menopause, and actually we should be driving to normalise it. And you can agree or not with that, but not everybody will have symptoms, but 3/4 of women will have symptoms, and 1/4 of women will have severe symptoms. And the average length of those symptoms will last for 7 years post-menopause. So this is a long chunk of time that women are potentially having symptoms which are potentially treatable. So I was hoping for a little bit of audience participation here, if anyone's brave enough. So how do you think the diagnosis of menopause is made? Husbands. Yep. Sometimes they only realise after you've started the HRT, right?
I think it's retrospect.
Yeah. So it's a clinical diagnosis, isn't it? So I think the important thing, the take-home message is that measuring hormone levels isn't recommended. So actually recommending that patients have their FSH or estrogen or progesterone levels is not advice we should be giving to people. These hormone levels can fluctuate throughout the day by day, month on month. So actually, even if your hormone levels are normal at the time period that they were tested, it doesn't mean that they're not fluctuating and low at other times. So there are lots of apps that you can use to monitor symptoms and kind of keep an eye on things, because a lot of them they kind of catch up with you. You know, you kind of don't realise, like you say, until, you know, you've been suffering for quite a while, that actually some of these symptoms may be due to hormonal changes. So why should we talk about MS and menopause? We're not GPs, we're not gynecologists. Is this our responsibility? Well, 30% of our current MS population are peri- or postmenopausal women. So I think it is incumbent on us to be aware of it, aware of the potential things that can happen and the interaction between MS and menopause. And this is a genuine clinic letter from about one of my patients. So, and this is a long time ago, by the way, so this is not a recent letter. But she'd been told in the past, I said in the past, a long time ago, not a current MS nurse, that she shouldn't have HRT on account of her MS, and they're unable to find any information with regards to this. And I think there's probably an understandable reticence on GPs, perhaps, to always advise in patients with MS, because they don't have the knowledge about MS, and so we need to empower women to go back to their GP and say, actually, you can treat me as you would any other woman with menopausal or perimenopausal symptoms. So I don't know how many of you were at the MS Trust conference. I wasn't able to be there, but I've managed to catch up with this. And Rachel Horn spoke very eloquently. She's a journalist who has MS and talks very openly about her experiences with MS. And she went through the menopause and had, I think, quite a difficult experience, and so went onto Twitter and asked other women what experience they had of their kind of menopause and perimenopausal symptoms. And I think the overwhelming feedback was that people weren't always prepared to talk about it, that neurologists didn't know about it, and I don't think this is unique to patients with MS. And I think there's a big disparity and differences across the country. And actually, from personal experience, I know kind of within the same postcode about how menopause is managed. So from this week, I kind of distilled a number of questions which I was hoping to cover largely today. These are the questions that the patients want to know. So these are the questions we should be prepared to answer. So does the menopause affect MS symptoms or disease progression? And we'll cover that. Do DMTs affect menopausal women with MS? Now, I think I can say that I probably won't be able to answer that, because the majority of trials for DMTs in MS exclude patients over the age of either 50 or 55. So actually, menopausal women aren't being included in these trials. So I don't think at the moment we can confidently answer that question. Does HRT impact MS in postmenopausal women as well as their quality of life? And I'll cover a little bit of that. And what's the alternative if HRT doesn't work? What are the alternative treatments? And we'll talk a little bit about that as well. So I'm going to talk a little bit about the challenges and importance of diagnosis in menopause in women. I am going to talk a bit about, I've kind of delved into subjects slightly out of my comfort zone, but talk about HRT risks and benefits, and then talk about whether hormones influence MS activity, either in terms of inflammatory activity or worsening progression. And then does HRT make any difference to that? So I thought this was very instructive, but if you kind of list the main MS symptoms, and I don't mean, symptoms of a relapse, I mean the symptoms that patients suffer with day to day, and then you compare it with a list of menopause symptoms, and there is an awful lot of overlap. okay? And I think this is really difficult because patients are often coming to you in their early, mid or late 40s, and that's at a stage where their MS might be getting worse anyway, and they have these symptoms, and, you know, is it MS or is it menopause? And actually, we can say, I don't know, because sometimes we won't know, but I think it's important to acknowledge that it might be hormonal, it might not be your MS. And actually, if patients ask you that question, I had 2 patients I saw this week who visibly relaxed because they were a little bit nervous. You know, they came with their list and I said, I just wanted to say, you know, could it be hormonal? And I was like, well, actually, now you mention it, maybe it could. And, you know, there's a physical relaxation when you're prepared to talk about it. I've picked my kind of top 3. These are possibly the top 3 symptoms that patients with MS have. So problems with sleep and fatigue. That's an incredibly common peri- or menopausal symptom as well. Mood and cognition and mental health, so increasing anxiety, brain fog, memory disturbances, depression, all common in MS, but also pretty common in perimenopause, and urinary and sexual health. And I think not only are these 3 of the symptoms that are most common for our MS patients, they're often the hardest to treat as well. And often patients will describe these symptoms and you're kind of like, yes, that's really common. I'm not really sure I can do an awful lot about it. But actually, if you've got a woman that's perimenopausal that's also got these symptoms, potentially treating with HRT may help some of those symptoms, and I'll show a little bit of evidence for that as well. I think urinary and sexual health is a particular one, and even in women that are perhaps HRT is contraindicated for reasons either concerns about breast cancer or family or previous actually have had breast cancer, then vaginal estrogens can be used in pretty much anywhere. They're not absorbed enough to give systemic raises, so actually and can be really effective at treating and trying to prevent kind of UTIs. So there are lots of other risks to the health from the menopause, osteoporosis, an increased risk of fragility factors, and we know that our patients with MS are also at higher risk of that. Obesity, and we know that because some of our patients with MS struggle to exercise as much as they would like to, struggle with weight. Raised cholesterol, cardiovascular disease, diabetes. We know that treating comorbidities is really important as well with our MS patients. And osteoarthritis, again, will have, plays into problems with neuropathic pain. Is it arthritis? Is it neuropathic pain? So other health risks which kind of coincide. So there are lots and lots of potential benefits of being on HRT for all women, predominantly for control of symptoms and improving quality of life. And that's really the main basis of giving HRT. There is also a suggestion that there's some protection against cardiovascular disease, predominantly if it started early or within 10 years of the menopause. It's good for bone health, so it increases bone mineral density and reduces the risk of fragility factors. And it may relieve short-term cognitive symptoms. I think it's important to point out that there isn't the evidence that it reduces the long-term risk of dementia, but it may help with the short-term cognitive symptoms. And a study published last year, there's been lots of kind of looking at and I think up until quite recently, the advice from certainly the US has been not to prescribe HRT for future health to reduce cardiovascular risk. So it's predominantly meant to treat symptoms. But actually this study, which was a matched cohort study performed in the UK, which took a lot of patients, over 100,000 HRT users. So this isn't MS specific, but they're matched controls, and actually found that combined HRT was associated with a 9% lower risk of all mortality. So suggesting some benefit in all-cause mortality with combined HRT. There was no difference in mortality with estrogen only. So I thought this was quite instructive, and not to be too oversharing, but this is when I graduated from medical school. So you can see that this is numbers of HR, proportion of women with hormone replacement prescriptions, and this dropped off quite precipitously in the early 2000s. And it remains low, and it remains a low proportion of women are prescribed HRT. And the main reason for this was the publication or early leakage of some data from the US, the Women's Health Initiative, which was looking at the risks and reported an increased risk of breast cancer in women on HRT. Now, I think we can't say that there isn't an increased risk, but I think we need to just put it in perspective. So I think this is a really useful infographic. I suspect a lot of you may have seen this before or perhaps used it in clinic. And it shows the difference in breast cancer incidence per 1,000 women aged 50 to 59, and the approximate number of those of women developing breast cancer over 5 years. So if there are 23 cases of breast cancer diagnosed in the UK general population, there will be an additional 4 cases on women on combined HRT. Actually less if it's just estrogen only. So estrogen only HRT appears to reduce your risk of breast cancer. The pill also increases your risk of breast cancer, but we don't have the same kind of reticence in prescribing that. Drinking alcohol is more risky than HRT. Smoking is more risky, and actually being overweight or having a BMI greater than 30 is several times more risky. The good news is that if you exercise, then you can reduce your risk. So I think we have to be honest that there is a risk, but we need to put that in perspective. And actually, it's incumbent on us to provide patients, women with information, allow them to make the decision. So I think there are a few other risks. So an increased risk of venous thromboembolism with oral HRT preparations, but it's lower than with the oral contraceptive pill or with pregnancy. A slightly increased risk in stroke in those over 60, but less with the transdermal estrogen, so patches or gel. And a slightly increased risk in those over 60 taking HRT for more than 10 years. But again, if you boil that down to what it actually means, over 5 years, 2 in 100 women taking HRT are at risk of heart disease compared to 1.5 not taking HRT. So yes, it's increased, but not dramatically. So I think one of the reasons that HRT scared me a little bit at university, apart from all this, was it appeared really complicated. But actually, having read a lot more about it, it isn't really that complicated. And this is quite a good schematic diagram. And the type of HRT that may be most appropriate to you, it depends on whether you've got a womb or not, and the Mirena coil. So hysterectomy or Mirena, you go down one estrogen-only line or combined estrogen and progesterone on the other line. But I don't think it's incumbent on us to be making decisions about what type of HRT people are on, but empowering women that there is a choice. And we know this is about, shared care decision-making and giving people enough information to make their decision, much like we do with disease-modifying therapies. So obviously it's really important. HRT isn't everything. There are kind of, I think, probably 2 camps in the kind of menopause world. One very proponent of HRT, very pushing it, and I think it very much has a place, as I've just described. But there are alternatives to if patients either can't take HRT or don't want to take HRT. And we know, of course, that lifestyle modifications are super, super important. So diet, exercise, stopping smoking, all those boring things that we tell patients to do and try to do ourselves to a certain degree. I'll talk a little bit about the herbal alternatives and magnesium. Clonidine isn't often prescribed. It's a drug to try and reduce kind of flushing. And gabapentin, pregabalin also have their role, and also the antidepressants. And again, think that people vary about how But if people have low mood, whatever the cause, then people shouldn't be afraid of trying antidepressants, at least a trial of them, if other avenues haven't worked, and they can be very effective in some people. So I had a quick look about complementary treatments, and one of my favourite statistics is this, that the global wellness industry is worth $4.5 trillion US. You're going to ask me what the pharmaceutical industry is worth, and it's 1.4 trillion. So the wellness industry is worth 4 times that of the pharmaceutical industry. So I always take it with a little bit of a pinch of salt when you kind of Google any of these therapies. There's lots of information, lots of pushing complementary supplements and things, and I'm not saying they don't have their place, but I think we need to be very aware that there actually isn't a lot of good evidence to support their use. So, for example, the soya isoflavones, there's a small study of about 50 patients in total showing some benefit. Magnesium is one of those things that actually I think has a potential for benefit in lots of areas, so sleep, headaches, mood, muscle aches and pains. The evidence does not support its benefit for hot flushes, but for other symptoms it may be of benefit. And I usually say to patients, give it a go. If it helps, that's great. As long as it doesn't harm you and it doesn't harm your wallet, then crack on. But be aware that there isn't a lot of evidence for them. I think St. John's wort is one thing which is important to be aware of because it can interact with other medications. So St. John's wort is sometimes given for mood and anxiety, and there has been some, again, small studies for hot flushes. But it can reduce the effectiveness of fingolimod, that's a BNF interaction, and it can increase the risk of things like serotonin syndrome with medications such as duloxetine. These are obviously drugs that a lot of our patients are taking. So I think the big question, which is complex and I don't think we know the answer to, we need more research on, is does menopause affect MS disease course? And we're aware that sex hormones must have a role somewhere, and I'm hoping there may be some genetic reasons as well, but we see that the increase in prevalence in women occurs in puberty. We're well aware that relapse rates reduce during pregnancy, but then increase afterwards. So pregnancy is a time when we have a lot more estrogen on board, and the preparing when it drops. And then progression is a slightly different story, which we'll come on to. And I don't, come on to this, we can talk about this at the end. I don't think it's as simple as, say, estrogen being anti-inflammatory, because there are lots of different types of estrogen, and actually low-dose and high-dose estrogen probably have, so low-dose estrogen may be pro-inflammatory, whereas high-dose may be anti-inflammatory. So it's not as easy as saying, this hormone is anti-inflammatory. So there has been some work done to try and look whether the menopause affects progression and the rate of change in disability and relapses. And this was a study from Italy and did show a faster rate of EDSS worsening observed after the menopause, more marked in smokers. And the relapse rates declined after menopause. But this was one study, and actually a systematic review which aggravated this data with another study suggested there was no difference in relapse rate before and after menopause. So, and we also obviously know that men, this is the age, as we know, around kind of mid-40s, where we expect people to start getting worse and having progression. So the evidence seemed to say that the evidence doesn't suggest that the worsening is due to the menopause. And this was a Barcelona big cohort which looked at the EDSS trajectory in menopause and non-menopausal women and didn't find any significance after adjusting for age and disease duration. So there isn't really support for the menopause causing a worsening in disability. So I think that can be relatively positive for patients, can't it? So what about the impact of HRT on MS as a whole? So this is an early study, and it's kind of sad that this is probably, this is almost as much as I could find about HRT on MS symptoms. And it was from 1992, but did show that that patients or postmenopausal women reported a worsening of symptoms, as we've kind of discussed, that one might expect. But actually, people treated with HRT reported an improvement in those symptoms. It is a small study, but it supports the use of HRT. However, a more recent Danish study looked at patients with HRT. I think it's striking that only 10% of these women had received systemic HRT. Again, they didn't find any difference between HRT and disability accrual, and actually a possible increased trend for progression taking HRT for a long time, and an increased risk of relapse in current users. But actually, when you looked at those women, that was in a pre-high efficacy data. So I don't think this is enough to say that HRT causes MS to get worse, but it just gives that kind of caveat that we can't, we don't know enough about it and we need more research. From a symptoms point of view, there's some data from the Nurses' Health Study suggesting that HRT does improve quality of life. It might not reflect causality and direct effect on MS, of course. So we talked a little, I've mentioned, could estrogens be anti-inflammatory? And we do have a bit of evidence to suggest that they might be. And there are a couple of studies using estrogen in combination with disease-modifying therapies. So this one using it with glutathione acetate. And actually, the patients who had estradiol and glutathione acetate did better in terms of relapses than those just with placebo and glutathione. And oral contraceptives combined with interferon in MS, again, the oral contraceptive pill seemed to reduce active brain lesions compared to just using interferons alone. But I think we desperately need more information about this, and we don't have enough to be kind of conclusive. And like I said, it is a complex area because the kind of types of estrogen and the doses need to be elucidated further. And also I think we just need to not forget testosterone. A few nods from the audience. So testosterone is also a hormone that we have as women, and it's produced by the ovaries. It seems to be lower in women with MS than in controls. And actually, in a study of men with relapsing remitting treatment with testosterone improved cognition and reduced brain atrophy. So I think that's another area for research, and there is potential role for testosterone in inflammation and neuroprotection. Currently, there isn't really any evidence to support its treatment in menopause outside the current recommendations, which is for libido rather than anything else. So, what's our role? We need to break down the taboo and start talking about it, don't we? We need to empower and advocate for our patients. The role of hormones is complex, and I think more research is needed. But this is a real opportunity to take each woman as an individual and an opportunity for personalised healthcare. So I've certainly learned a lot, and I now ask patients of the appropriate age about their periods and about vasomotor symptoms, and that leads on certainly to other discussions. I am aware that menopausal symptoms may mimic, but actually treating menopausal symptoms or perimenopausal symptoms is probably easier than treating a lot of MS, treating the symptoms as if they were purely due to MS. The decision to start HRT will be different from person to person, and those risks and benefits need to be weighed up from woman to woman. But we do need to advocate for our patients and empower them, because not all GPs, and I say this with a fair amount of confidence, are as up to date as they could be regarding menopause and perimenopause treatment. So I have finished a bit early, so there's plenty of time for discussion and questions. I did want to thank Rachel, who gave me permission to share her story on Twitter, Wallace, who shared a presentation with me, Ruth, and the two Ruths, Ruth Dobson and Ruth Strauss.